shift, and then the ET tube is
goes one side or the other.
Yeah.
So you want this to be snug on their head, but not tight. So I'm not trying to stabilize their C-spine.
Well, I always try to make sure I see their ears.
Right.
On each side, and then they're kind of square.
Right.
And then we do the twill, you know, to try to secure.
Right. So for me, a lot of times when I come in, for you guys that have been here, whatever, around our patients, a lot of times I'll come up here and go, the patient's shoulders need to come over. So the reason why their head is cattywampus in there is because when you initially put them on, they're not square. So square them up. So a lot of times that's just me slipping my hand into their back and pulling them where they're actually in alignment. So sometimes they're not in alignment. The number two problem with that is that in the morbidly obese patient or the larger patient, when you turn them into the prone position, if you don't crank them in, when they start to rotate, all that body weight starts to shift, and so the head's here and the body starts to shift, and then eventually the body gets torqued on that turn, so the head starts to turn as well. So that's one of the things that I teach, is that when we're ready to go, I'm going to put this headpiece on. Now my third is, we've gone from the inside out and the bottom up pads. The second bottom up is doing those. The third bottom up is tightening them as tight as you can tighten them, okay? So one of the things that I teach when you go to the prone position is real basic. You do your ABCs, airway, double B, which is the butt pack and the breathing, the thoracic packs, and C is the crank instead of circulation. A, airway, watch the airway. B, open the breathing packs. And I added the extra B because you want to open the butt pack, especially if you have all the padding underneath them still. And then C is crank them in, okay? So it's on the right side, but when you turn the patient over, it's going to be on the left side of the bed, okay? So crank, tighten them in. And I'm talking, yeah, tight. Static, nice and tight as it will go. Now, when I tighten this, I've taken my EKG leads off. So the last thing I take off, I remove them to the patient's back. Okay, but when I tighten this, especially if it's a very large patient, it's going to give you no or low tidal volume, right? And a very high airway pressure, because it's like you put an elephant on their chest. Their chest, there's like, oh, you can't get the tidal volume in, okay? So I want to be ready immediately to turn the patient. So before I tighten this, like it's the last thing I do, you're going to follow all the prompts at the foot of the bed. Check tubing, check airway, check head support. When it asks you to check the face mask, check it, and then tighten this, and you'll be ready to go, okay? So what do I do first when I put the patient on? How do I rebuild the Rotoprone?
How do you rebuild it?
How do I rebuild it?
Start with the face mask.
Okay.
The face mask, correct.
Okay, and then?
And then inside out and up.
Good. And then what goes after the inside out, what, after the external pieces, what's next? With what? Pads. The pads, right. And then what's after that?
The rails?
Yes. The arms, right? Okay. And then the last thing? Tighten. What am I going to leave open? Starting from the foot of the bed. The digits, your toes, right? Try to keep it off the knees. What else? Open belly. And these have to be all the way at the top. These have to be all the way at the top, right? Okay. All right. So now we're ready to turn the patient. So we're going to go to the foot of the bed. I want it to be nice and snug in. Okay. And then for whoever has not done the buttons before, come out and do them. Okay. So just follow this very unattractive guy with no face here. Pull the lock pin. Okay, and just follow the prompt. So you're gonna be here. You're gonna have another licensed person at the head of the bed. So
and I will say check tubing.
Right.
Do I
Tubing's
push it
good.
as
Yes.
I say it?
Tubing's good.
Check airway.
Airway's good.
Check head support.
Head support is good. Start rotation.
Start rotation.
Then you want to prone the patient.
Prone.
Press and hold. And you hold that into a new screen, pop your legs. Then you have a really long laundry list of
Okay.
things. Tubing
So
is
check
good.
tubing. Check airway.
Airway good.
Check head
Head
support.
support good.
Check arm slings.
Good.
Check abdominal support.
Good. Now here's your face pack check. The reason why it prompts you to use an extra prompt is because there is no alarm on the face pack. Because when the patient is supine and rotating during kinetic therapy, they don't have to have the face pack on. So there's no alarm attached to it. It obviously is like one of the most important parts to have right. So you guys are in here, respiratory comes in because they realize that the anchor fast is still on there, or they want to add a little something, or you brought the twill tie in, you can't quite get it where you want it, so you hook one side of it. Make sure that you come up here and check and make sure it's good. Pull up on this and then tighten this, right? Think about how much time, even if I wasn't talking, check tubing, check airway, check head support, start rotation, prone, rotate and lower. That can be like a minute. So a minute with no tidal volume is gonna really piss the patient off, and you can also have the potential of having a pneumo because you get so much pressure, okay? So here, and then go. So we want to prone.
Confirmed.
Right. So go ahead and hit prone. And so if we prone this way, the vent and the vent's over here, that's not going to be good, right? So one of the things you want to go to is you're going to cancel that. You're going to go to the overhead support. You're going to go to therapy settings, and you want to set it to go which way?
To the left.
So that's counterclockwise. So
Yes,
tap that.
counterclockwise.
Tap counterclockwise.
Okay, and then push?
Counterclockwise, and now go to your home screen.
All right.
And I'm gonna let you go without any instructions. So you're on your own, you're in the room with me.
All right. Rotate and lower? Okay. Just leave it?
Until you get a new screen populates, leave it until a new screen comes up, all right?
Okay, here we are. Check tubing,
Tubing good?
check airway,
Airway good?
check head support,
Support good.
check arm slings,
Good?
check abdominal support.
Good?
Reconfirm face pack is in place and
It's
secure.
good? Good? I'm gonna tighten this,
Okay, I'm
Okay.
confirming.
okay? Now we're ready to go.
That's it.
Okay, so press prone.
Prone.
So you have to press and hold it, so nobody can, like, come by
I
and
see.
hit prone. Just for grins and giggles.
Do I just keep rolling?
Yes. So this is the piece I was talking about, and I want you to come up here and look. So I've done the airway, A, okay, B is gonna be, so I've transferred the patient over on the lift. You can leave all the bedding, all the linen, the lift, everything underneath them. You don't have to turn them, especially if they're really unstable, because the more you turn them, the more agitated they're gonna get. Plus you're getting ready to do the big kahuna of turns, right? So you open this here. Here's your first B, I did the airway. Here's the wet pack, and then the breathing pack. So I can pull all of my linen out now. Open this. Okay. And now C is gonna be crank. So if you have a really big patient and you turn them over now, all of that, even a smaller patient, usually you can go 2 or 3 revolutions. I've had a patient where I could turn it 13 times after returning them. They had so much weight here. When we turned them over, all that pain fell forward without having gaps like this on either side. That's what happens when the patient's head is turned sideways, because if they're stable in here, now I've turned them and I don't crank them in, as they start to rotate 62 degrees, all that body weight shifts and eventually starts to pull the head as well, and all the body weight shifts. And that's how they get jacked up or
Cattywampus.
right, cattywampus, okay? So go ahead and crank them in. That's your A, B, C crank. We're gonna do a couple of cranks until it's nice and tight, until you meet a fair amount of resistance. And now you're ready to go, okay? Your chest film goes here for chest x-ray. Okay, be careful because this does not stay up. Okay, when we had Joel on, we were just talking about Joel a minute ago, I was teaching that day, and I had my hand right here and somebody dropped it and it slammed on my finger, and you can lose a fingernail or cry in front of your peers or whatever. I did all of the above. So, anyway, and then you're gonna put your EKG leads on, okay? So just remember now white, green, brown, black, and red over here, okay? So just put it in the same position you would, except for I try not to put the brown lead, I call it the gravy lead, that's how I teach kids, underneath this pad, put it off to the side, okay? All right, and then I try to open the foot pack as well, just so that there's no pressure on the heels. And so when I say that the most common places that we find a breakdown are on the face and on the heels, one of the things that you can do is that you can put this pad underneath here. And you want to be careful that you don't include the Foley, but you can put this here, and it will help hold that up so that you have absolutely no pressure on the heel, okay? Then you can also do range of motion. You can slip the patient's foot off that foot pad and do range of motion where you can even, as they're in the prone position, their feet could be here. Does that make sense? Like if you lift them up, their foot can maybe rest here for a little bit and give them the bottom of their foot a rest, okay? All right. Questions up to this point? So ABCs, you get them turned over. Now, remember when I said this does not have to be really, really tight up against their face. Now, sometimes when you turn the patient, they have a big bowling ball head. Their head will fall forward a little bit. And so you do have, there's not enough room sometimes for the circuit
Right.
with the face pack. So sometimes you will have to push the face pack up a little bit to compensate for, but now the face is in here, and you're gonna meet that resistance, so you're gonna lift it up just enough so the circuit can fit under here. You don't wanna break the circuit, okay? And then when we're talking about the person whose head looks like it's falling forward, watch this when I do this crank. Come and look at the headpiece. See how it moves the head up and down? See how it's moving up and down? It's moving down now for the frame, and then this will lift it up. So they're talking about that this morning, moving the whole head. So it's either going like this
All right.
or like this. So you should always have about 2 finger breaths here. Anything more than that, this is typically the standard, what fits best for everybody. But when you have those one-off, somebody that's got kyphosis or something else going on with their head, and they look like their head's either this way or too far forward, you can turn the crank to adjust that. Okay?
Tara, can you show the tilting? There was you could to
Yes.
the side.
So if the patient's static prone, say the patient not tolerating turning from side to side, and they're just static prone, you think, man, they need some pressure relief on their face. You can pull this knob right here and then move the patient's head from side, and that will lock into place to side here as well, and it will lock into place. So each station has a lock. Obviously that you would want to do that. Here, 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 straight down, here, here, and then all the way over, okay? This is also good. I said this morning, like if you're turning a patient over and something has happened, they have to be reintubated, or I hate to even speak that over anybody, but since there's not a patient in here, I guess I'm not. So, and they're starting to aspirate, so you can also use this when they're supine to quickly pull out and turn their head sideways so that their heads turn sideways and they're not straight back here. Just remember, if they throw up in the prone position, they're actually throwing down, right? So the risk of aspiration is much less. Okay.
Oh, yeah.
Questions up to this point? Those are some good questions this morning about the headpiece. What if, you know?
Yeah, because we're always having some problem there.
Right. So this is supposed
It's
to
like after we all crank it up and everything like that, and then, okay, it's not in place. After
Right.
we see the ear, the eye, and everything like that, and then when you turn on prone, they just
a lot of times it's a crank, so you get that alarm that keeps
Or
it
just
alarming
like-
you. There's a buckle or a
We just
hatch.
did that.
Yeah, exactly.
It'll tell you there's a buckle or a hatch. There's a buckle or a hatch. Most of the times, if you call me instead of calling the 800 number, I'll tell you crank the black handle in. You crank it in, and it will stop all those alarms. But by that time, the patient may have already shifted, and you're going to have to flip it back over. So a couple of things. The New England Journal of Medicine study that came out last May, that was presented at the American Thoracic Society last May and presented and published in June, said that the patients that they're able to show a greater than 50% mortality, drop in mortality at 28 days were those patients that were prone within 12 to 24 hours. At 90 days, they still had a 42% reduction in that patient population. 82% of those patients were orthoseptic. So we're talking the sickest of the sick patients, okay? Surviving sepsis guidelines came out last year that list proning as a grade 1C intervention, which is safer than high peaks. Okay, so proning went from a risk of being a high risk maneuver to do as in a category like E, which is like the Enigma, don't ever do it, to like a 1B, which is a huge jump. It's standard of care. So Surviving Sepsis campaign came out. The New England Journal of Medicine article came out. We already had SUDMED, SIBO, those other studies, but the patients were prone in those studies for 16 hours continuously without being turned. So I beg of you, if you have a patient on 100% FiO2 with 20% of P, and they look uncomfortable to you, and you turn them on their back, you know, studies have shown that the patients that stayed prone for that continuous amount of time had better outcomes. There's a study that just came out in January 2014 in Intensive Care Medicine online from Harvard that's a meta-analysis looking at the same patient population that the Guerin study from New England Journal of Medicine was looking at, and for you respiratory people, they were looking at specifically, they narrowed it down to patients with, in 2,000 patients, 1,000 of them were in the prone position, so patients that were prone that had low tidal volume ventilation, they had even better outcomes than the Guerin study. It's a meta-analysis, but they were looking at what is wrong with all the previous studies, and it probably had to do with the stratification of those patients with low tidal volume as opposed to those with high tidal volume. High tidal volume being defined as those patients with 8 or greater milliliters per kilogram of ideal body weight. So In that study, it actually showed a relative risk of